Welcome everybody to 52 Living Ideas. I'm honored to have Dr. Rick Lippin here. He's a recognized leader in the medical specialty of Occupational and Environmental Medicine, OEM. He practiced for 25 years and held senior positions at ARCO and other places. His most recent position was Corporate Medical Director for ARCO Chemical Company, where he had the responsibility of management of occupational environmental medical programs on a worldwide basis. So he's lived this, and he has some really powerful ideas about what is happening in medicine and what we need to do about it. So welcome, Rick.
They're looking up at your nostrils.
Hi, Shrikant, and thank you very much for hosting this and helping me with the technology on Zoom. And thank you all participants for spending part of your Saturday with us. The good news is I'm coming in from Bucks County, Pennsylvania, 28 days and counting till spring. So I think we should all look forward to that after a very, very tough period of time in our world. So as Shrikant said, there's a lot to cover here, and each one of these megatrends could probably have a session of its own. But we'll do our best to address each of the 7 megatrends, and I really appreciate your input. Let me say that most of the megatrends, they're not really breakthroughs. They've been around for years, if not decades. But
Rick, can I ask you a question? Just
yes.
as a background question.
Yes.
So your approach to medicine is not the traditional approach, but you were trained as a doctor. So at what point, what was your process of discovery of these fundamental issues in medicine?
Well, yeah, okay. Historically, I went to Temple Medical School in the late 1960s, many years ago. The Vietnam War was raging. There was a lot of political unrest in the nation. And Temple Medical School and Hospital was in the middle of a ghetto, a black ghetto in North Philadelphia. And I would go see the patients as a doctor, as a medical student at Temple. And there was a disconnect between what I was seeing at the bedside with my patients and what the professors were teaching me about medicine. So the first megatrend, really, I talk about organized medicine as being very limiting. The emphasis in organized medicine, I was taught, was mostly pharmaceuticals and surgery. That's core treatments. But there was like a total absence of the professors talking about cultural issues like the war that was going on. My perception was that the patients in the bed at Temple University were there fundamentally because of poverty. Mm-hmm. And I noticed this disconnect between, and that began my entire journey into challenging what I would call the traditional organized medicine. But the breakthrough, the megatrends that I'm talking about today are not really breakthroughs, in my opinion, but there's a great still in the year 2021, there's still a great deal of resistance to these concepts that we're going to be talking about today. As a matter of fact, one presentation that I made years ago in Colorado was why is there so much resistance to these obvious trends that are occurring in medicine? And it has to do with resistance to change in general, and people having an orthodoxy and not willing to change their models or their paradigms. So let me also say that no nation on the planet has figured out and ever will figure out healthcare completely. Why? Why is that true? Because there's the famous three legs of the stool of all of medicine. The first is quality of medicine. What kind of medicine are you getting? The second is access to that quality. And the third is affordability. So when you look at quality of medicine, access to that quality, and affordability, you have to make choices. So in countries where there is single payer or socialized medicine, there's an accusation that people can't access medicine as quickly as they can in the United States. But we have a problem with affordability, for example. So no nation can maximize all three, or because they will totally decimate their gross national product. So those three stools need to be kept in mind when looking at any healthcare system. And no nation has figured it out completely. In my opinion, the electorate in these countries has to decide what they want, and what they want to sacrifice. In my opinion, there's some value in sacrificing some quality and technology in favor of access for all and affordability. That's my political view. The fourth thing I'll mention is that, let's see what I had here.
Folks, I have put the summary of the 7 megatrends in the chat, so you can open it up on your own computer. You can print it out if you want. Thanks. Go ahead, Eric.
Okay, so I'll just skip and go to the megatrends. And thank you for putting up. I listed 7. There are many other megatrends that are occurring in medicine, but let me start out with organized medicine. I hope everyone here understands that there's a difference between medicine, organized medicine, and the broader concept of health. You know, certainly the World Health Organization has taken a broad view of defining health as a complete physical, mental, and social well-being. So it includes not only physical health, but mental and social well-being. So that's a huge difference between what US medicine, organized medicine, emphasizes, which I just said that at least since my training in the 1960s, organized medicine has basically emphasized pharmaceuticals, which highly dominates the medical practice, and surgery. There's a lack of funding, and there's a lack of interest in doctors addressing generally the mental and social well-being of patients. And let me tell you that, again, this has been known for decades. Stephen Schroeder from University of California, San Francisco campus, he has a paper that came out that dealt with this issue of what really contributes to overall health. And it's quite shocking that organized medicine, in his opinion, only accounts for 10% of contributions to premature death. The other factors are behavioral patterns, genetic predisposition, social circumstances, environmental exposures. So organized medicine, or the healthcare that you and I get, at least in the United States, really only accounts for 10% of our health outcomes. So that's a good example of the limits of organized medicine. Within Schroeder's paper, the behavioral issues he breaks down, US numbers of deaths, and again, this was in 2007, quite a while ago. The behavioral issues, numbers of US of deaths from behavioral causes, smoking and obesity are the 2 largest factors that impact that fall within the behavioral components of causes of premature death. So I want everyone to really understand that when you talk about medicine and when you talk about health, they're really 2 different concepts: health versus medicine, medicine versus health. And health is a much broader concept, and hopefully, as we move along in our society, there'll be much more recognition that health in the broadest sense is really something we all should embrace. Later on, before I finish, I'll give you my own personal prescription for what, in my opinion, constitutes a good health practice. So let's go on to the second megatrend.
So Rick, can I ask you just a couple of questions?
Yes.
I think this is a huge point, because in some ways it's the fundamental point, because we are trying to maximize our health. And what medicine is trying to do is at most reduce. Lynn, we are fine. Lynn, we are doing fine. Okay. So the medicine is mostly focused on disease. And even at the disease level, it seems to be focused on managing the symptoms of the disease, rather than looking at the entire organism and trying to say what is going on with the organism and what constitutes health for the organism itself. Is that fair?
Absolutely correct. Absolutely correct. I mean, I would, you would go to your doctor, or anyone online here today would go to your doctor, and he doesn't ask you, how are things at home? How are things at work? How are your relationships? What's your zip code? You know, one of the cliches is that zip code is more important than genetic code. So doctors really have to expand their understanding of their interaction with their patients and include these factors. And they're beginning to do that. I went to a primary care doctor for the first time in a long time myself after I retired. And he did have a question about depression on there, which was a breakthrough, in my opinion, because so many doctors don't even bother. They're so obsessed with the physical side only, the cholesterol, the blood in the stools, the weight. They're so obsessed with that stuff that they fail to talk about all the psychosocial interactions with the human health.
Excellent. So shall we go on to prevention?
Yes. Well, I think at least in the United States, because of the enormous success of the miraculous successes of pharmacology, pharmaceuticals, and surgery, as you said before a minute ago, Shrikant, prevention really gets short shrift in U.S. medicine anyway, compared to all the medical expenditures. I think prevention still only gets less than 5% of the total dollars spent in medicine. And the public health infrastructure, unfortunately, you know, even in regard to the pandemic, it exposed this, has been decimated by the overwhelming influence of treatment instead of prevention. So we in preventive medicine have been frustrated for decades that there's not enough emphasis. The other side of the coin is that, you know, the head of the NIH years ago, Elias Zerhouni, said the high cost, high tech treatment model of medicine is just not economically sustainable. We need to move toward prevention and exporting the high-tech, high-cost treatment model of medicine to underdeveloped countries or developing nations would be a catastrophe. There's not enough money. The technology in treatment has gotten way ahead of our ability to apply it to the billions of people throughout the world, or even in the United States. We can't afford to apply, for example, transplant technology or renal dialysis technology to all people above the age of 65. So people get scared when you say that because it brings up the nasty R word called rationing. But there is no question that unless we move toward prevention, the high-tech, high-cost treatment model of medicine will bankrupt our not only health economy, but our entire economy. So there's an imperative to do prevention. And there's a lot of good evidence that prevention works, but it takes, I like to talk about individual preventive measures. That is, the individual has to take responsibility for changing their behaviors, but even more importantly, institutional prevention. So, we must, for example, provide economic incentives for doctors to talk about prevention, Shrikant and the others, when you visit them. Doctors need to talk about your smoking habits, your dietary habits, your stress levels. And there needs to be compensation to the doctors to be able to do that. So I foresee in the next 20 years a transformation of the healthcare system toward prevention, Shrikant. But it's going to be very painful and very difficult because the moneyed interests that are very much invested in treatment are extremely powerful. They have a huge lobby, the largest lobby in Washington, D.C., much larger than the defense industry lobby even. And you don't have to be awake to see that the pharmaceutical industry dominates the airwaves with direct-to-consumer advertising on a daily basis. This is a huge challenge to the preventive medicine community to try to overcome the tremendous political and economic resistance to prevention, because treatment is big money. And we all know that when we see the hospital bill. And I am not one who wants to throw the baby out with the bathwater. I believe in the miracles of drugs and surgery and radiation, but I like to talk about treatment plus prevention with a slow incremental transition to much more emphasis on preventive medicine.
Excellent.
So that's prevention.
Wonderful. So, I know, Rick, you can talk about each of these points for a long time, but I want to make sure that we cover everything. And then what we will do is that we'll give an opportunity to the audience to discuss it amongst themselves, and they will bring up whatever areas that they want to focus on, and we will deal with them. So we'll put up, this amazing tray of issues in front of them, and then let them choose which ones that they want to focus on. The next one is caring.
Yeah, well, the reason I got to this issue is because of the demographics of the aging population and the death and dying issue, the hospice movement, what they call palliative medicine. I spoke at the New Jersey Hospice Association about 10 years ago on this topic. And it relates to the fact that Americans, by and large, are very much obsessed with technology bailing us out of even death and dying. And the palliative medicine community, or the hospice movement, really emphasizes that in addition to curing cancer, for example, that would be a reason why people die, that caring is equally as important. Again, it's not a matter of throwing the baby out with the bathwater. The oncology community, of course, wants to cure as many cancer patients as they can, but there comes a time when they realize that the patient is going to die. The patient is going to pass away. So that kicks in the entire model of caring for people, giving them a dignified, pain-free death. We in the United States are behind other nations in terms of dealing with this issue, but I think we're getting there slowly. But we have I would call an immature attitude that technology cures everything, and it doesn't. I made a maybe a joke at the Hospice Association meeting that I spoke at. I said, the only thing that really gets cured is pickles and ham. Ham can get cured and pickles can get cured, but human beings, there is no cure for the human condition. And while there are organizations who actually believe in immortality and they have some legitimate scientific hopes, I think it's pretty reasonable to say that most of us are not going to get out of this game alive, at least in our lifetime. And as we reach a point in our lives when we're going to pass, there's really a great deal of value in understanding how to care for people as well as curing them. And that's why I put that mega trend in there. The great humanist physician, Sir William Osler from Canada, he was one of the founders of Johns Hopkins University. He was a great diagnostician in the early part of the 20th century, but one of his famous quotes was, you need to understand the patient who has the disease as much as you need to understand the disease. So it was a humanistic approach toward medicine that William Osler had. And one of other Osler's famous quotes was, if you listen to the patient, they will always give you the diagnosis, but doctors have to listen. And that's part of caring. And, unfortunately, doctors don't have time to listen because there's an MBA who is telling them that they need to see so many patients per hour. And you can barely get your second question out to your doctor before he interrupts you. And it's because he has to move along, just like we're moving along today. And he doesn't really have time to thoroughly listen to your problem. But, I like to think of the two C's in medicine, curing and caring. And there's been no one can doubt the miraculous cures that we've witnessed from high-tech medicine in the past century. But it's time to rebalance the curing with caring. And I think the hospice movement, the palliative care movement, the death and dying issue is driving this caring humanism along. Okay. So we can move on to the next one, which is one of my favorites, number 4, a holistic model of healthcare. Again, reductionism, drugs and surgery has dominated US medicine in the past 50 years in particular. There was a physician by the name of George Engel from the University of Rochester. He was a psychiatrist. He was one of the first to put forth what he called a BPP model of healthcare, biopsychosocial model of healthcare. This was in the 1960s, and he was given some attention, but was totally overwhelmed by the enormous advances in technology in medicine that sort of lateralized George Engel's biopsychosocial model. Now, I gave a presentation in the early part of this century, early part of 2000, at the World Health Organization, at the World Future Society. It was part of that. And I actually added to George Engel's model. And I said, in addition to biopsychosocial, there's another domain, another S, biopsychosocial spiritual. So people like Larry Dossey and others have recognized that the spiritual domain is also part of a holistic model. So we're seeing more and more. I made this presentation at the World Future Society. I called it a BPSS model, biopsychosocial spiritual model of healthcare. And we're seeing more and more universities, medical universities, adopt this model. But again, it's I call it the macroscope is as important as the microscope. I mean, the microscope has been miraculous, but what about the macroscope? What about looking around you and seeing what other factors are influencing your health besides what we can see in the microscope? And that's happening. I mentioned before, one of the cliches in the field of holistic medicine is that zip code is as important as genetic code. And I think as time goes on, we will see an increasing acceptance of the broader model of holistic healthcare. A lot of, on a sophisticated level, they call it the application of systems theory to healthcare, which is similar to holistic application. So you have leaders in systems theory like Fritjof Capra, who wrote a wonderful book on the application of systems theory, not only to medicine, but to all of life. But you've heard over the years about holistic medicine. And I think we're going to be seeing an increasing emphasis on that model as time goes on. So that's number 4. Number 5 is what is called as personalized medicine. Now, if you watch TV, the oncology community in particular is emphasizing what they call personalized medicine, driven by the unraveling of the human genome, which was a huge advance in medicine. Let me see when that occurred. Anyway, so the human genome was unraveled several decades ago. I think it finally was unraveled and fully defined in 2003. And there were comments made at the time that this would, quote, revolutionize medicine. And it has certainly made a contribution to medicine. We hear a lot about sequencing genes, even in regard to the pandemic. They're now sequencing the viruses, the genes of the virus, so they can build better vaccines. But it's been disappointing, the unraveling of the Human Genome Project in terms of pushing personalized medicine has been disappointing in terms of its application to clinical medicine. The reason for that is that we thought, at least the early pioneers in unraveling the human genome, believed that there was a lot of possibilities that one gene could cause one disease, and that's simply not the case. For example, there are over 50 genes that are known to increase the risk of addiction. So there are not that many diseases in clinical medicine that are caused by a single gene. And I think that was oversold to clinical medicine leaders, that the Human Genome Project would be able to help us conquer many of the chronic diseases of modern man, like heart disease, Alzheimer's disease, other neurological disease, degenerative arthritis, a whole range of diseases that really don't yield that much to understanding them on a genetic basis alone. There are a lot more modulators of the human genome. The immune system is a modulator. The microbiome in our gut is a modulator. The nervous system is a modulator. So it's an enormous success to unravel the human genome. But I like to say there's another part of personalized medicine, and that is good doctors have been viewing their interactions with patients as very personal since the beginning of medicine. And the other side of personalized medicine is what we call narrative in medicine. Each patient has their own individual story. Shrikant has his own individual story about his life and his diseases and his interaction with his doctor. And the doctor should hear those stories. And you could even keep a diary about your own narratives in medicine. And some of the universities have tried to lead on this concept of personalized medicine, very much emphasizing narrative in medicine, the patient's own story. What diseases have you had? How has this particular disease affected you and your life and your loved ones and your job? This is important. And I would urge you that when you hear about the oncology community, the cancer community, talking about personalized medicine driven by genetics, I would urge you also to say, also another side of personalized medicine is each of our own stories, narrative in medicine, which you can read about online.
I just want to add one
Yeah.
thing. I grew
Yeah.
up in India,
Yeah,
and the way in which the medicine, especially family medicine, is practiced in India is that the
yes.
family doctor is the doctor of the family for decades. He
Wow.
knows everything about the family. He knows
Right.
your pattern. So when you go in, he remembers that 10 years ago you had that one, and he's actually keeping track of all of that thing. So they have got a sense of what is going on with a person, I think much more, because they interact with the human beings over such a period of time. So I find that, when I came to America, I found that was missing in America. The doctors did not have that almost the entire family and your individual life context
Right.
to use to see what is going on with you right now.
Well, let me ask you, Shrikant, is that still going on, or has the U.S. medical model interrupted that wonderful concept in India?
Yes and no. Yes, at the family doctor level, that is what is going on. But then, in the medical systems, if you get, cancer, or you get, heart disease, then it's a completely different kind of hospital system. So these are kind of small medical clinics, basically just one doctor, serving a bunch of patients in their neighborhood. Which is the kind of the primary family medical practice in India.
Well, some innovative leaders, I think Tom Frieden, for example, used to head the CDC. And I mean, innovative leaders in medicine are pushing for much more emphasis on primary care, the family doctor. We still have a dominance of specialties in US medicine, and the primary doctor doesn't make nearly as much money as the specialists make. And, the future of medicine inevitably has to move toward much more emphasis, not only on prevention, as I said before, but the primary care doctor, the family doctor, as you described, is going on in India. So let us hope and pray that we increasingly move toward that model. Thank you for telling us. We only have two more megatrends: alternative and complementary medicine. This is a huge topic in and of itself. I got to know a lot of the alternative medicine doctors early on in my career. I can name many of them. I won't. But my take on alternative medicine and complementary medicine, and other phrases, integrative medicine, is that the battle between that and traditional allopathic medicine is over. The war between alternative medicine and standard organized allopathic Western medicine is over. In my opinion, I like to say there's good medicine only. It's efficacious medicine and it's safe medicine. You know, one of the shocking reasons why we have to change our healthcare system is that Hopkins did a study years ago that shockingly demonstrated that the third leading cause of death after heart disease and cancer is medical errors. Now, can you imagine being part of a profession where your profession is trying to operate in a system where the third leading cause of death of patients is the system itself? That's insane. Now, there's been attacks on that particular article at Hopkins, and by the way, the pandemic has pushed COVID-19 as being the leading cause of death right now, but that's neither here nor there. But I wanted to emphasize that patients have always been way ahead of their providers in terms of trying alternative medicine therapies. And certainly the emphasis on nutrition as medicine is huge. And again, patients were way ahead of their doctors in this regard. But let me touch upon some milestones in alternative medicine. One of my favorite sub aspects of that is mind-body medicine. Now I'm sitting here, Shrikant, and I'm looking at this anatomical structure between your chin and your chest. What's the name of that anatomical structure between your chin and your chest? That's called the what? That's called the what?
Sorry, neck?
That is called the neck.
Yeah.
Now, why has Western medicine denied the anatomical existence of the neck? That's a fundamental, it sounds silly, but to this day, most doctors have not accepted mind-body medicine. Most doctors have not accepted that your central nervous system, which is above your neck, in your head, is profoundly impacting your body and everything in your body, from your cardiovascular system to your immune system to your gastrointestinal system. So leaders in this field are many, but Hans Selye, who was a Canadian, of course, he was the father of stress medicine, and he did his work in the 1950s. He defined what they call the general adaptation syndrome. And he said it's normal when your body is exposed to a stressor, it's normal for your blood pressure to go up, and it's normal for your stress hormones to go up, and it's normal for your pulse rate to go up. But if that becomes chronic, if it doesn't go back to baseline, then it can impact your health. So he was one of the great pioneers. Moving ahead several decades to Candace Pert from Georgetown University, psychoneuroimmunology. Candace Pert and her colleagues was one of the pioneers who began to understand how the central nervous system impacts our immune system. And our immune system is enormously impacted by stress. And Candace Pert defined that very eloquently and scientifically. So all of this has been proven, but still resisted. We had Herbert Benson from Harvard, who took a thousand-year-old technology called meditation, and he westernized it. Herbert Benson called it the Relaxation Response. That was his book. I went to visit Herbert Benson at Harvard. He was a very nice and welcoming doctor to me, a colleague, and we spoke about his work. His work was in the late 1960s, but he westernized meditation, and now there are millions of Americans who are doing active meditation on a daily basis and who are seeing improvements in their health. If you go to your doctor and your doctor doesn't ask you, hey, what are you doing about your stress? Have you tried meditation? I don't think the doctor is doing a complete job. Okay, a few others, just a few other names. You probably know the name John Kabat-Zinn, Z-I-N-N. 1982, John Kabat-Zinn was the father of what they call mindfulness training or mindfulness meditation. Huge movement in mind-body medicine. So as I said before, if Candace Pert talks about psychoneuroimmunology, all the specialties in medicine could put the phrase psychoneuro before their specialty. So you could say psychoneurocardiology. And a good friend of mine was a pioneer in that area. Robert Elliott, he passed away. Psychoneuroncology, psychoneuroendocrinology. All you have to do is put the phrase psychoneuro before any medical specialty, psychoneuroorthopedics. That is the recognition that the neck, the anatomical structure of the neck exists, and that the mind and everything that the mind perceives in our world and in our existence through the filter of the central nervous system on a daily and hourly basis is impacting our human physiology. If there would just be acceptance of that, medicine would advance significantly. But still, in this country, if you go to most doctors, they tend to lateralize that entire model. I hope that changes. I'm going to close with the global internet. Now, as I said before, some people who were involved in unraveling the Human Genome Project believe that unraveling the Human Genome Project, and by the way, they found about 25,000 genes in our human system, 23 chromosomes, paired chromosomes, 25,000 genes. They expected to find 150,000. They found far less. George Lundberg, he used to be editor-in-chief at JAMA, he and I agree that the global internet is far more important than the Human Genome Project in terms of its capacity to revolutionize medicine. Why is that? Why is the global internet so important? Why? Because about 250 million Americans have one of these, a cell phone. At least 50 million Americans on a periodic basis go to their cell phone for medical information or even a self-help group or a whole host of reasons how they use the cell phone for health reasons. There's medical apps now that technology companies are developing where you can actually communicate your EKG over a cell phone. There's telemedicine that is going on. But here's the key revolutionary aspect of the global internet. The key revolutionary aspect of the global internet is a shift from the paternalistic model of guild-like medicine where the doctor has all the secretive information and what I call the educated patients. Patients on a daily basis are aggressively accessing the global internet for medical information. They're coming to their doctors as the educated patient. This is a very different patient than our parents and grandparents who came to their doctors, not having knowledge. And the doctor was the all-knowing healer who had a secretive guild-like body of knowledge, which wasn't shared too much with the patient. The intelligent patient today is coming to their doctor with a fund of knowledge that they have pulled off the internet. If you have a rather rare disease and you research it on the internet, you are as likely to know more about your diseases and the advances in treating those diseases and diagnosing those diseases than your family doctor, because he or she, the family doctor, doesn't have the time to research every single disease that's rare. You, if you have it, have a vested interest in going on that internet and spending hours trying to learn about that. So George Lundberg, who used to be editor-in-chief at JAMA, Journal of the American Medical Association, said, and I agree with him, that by far the global internet is the modern revolution in medicine for many reasons, but mostly because you, Shrikant, and all the others online, you are coming to your doctor as an educated patient. It's an adult relationship. It's a co-decision-making relationship now. You're not waiting for the doctor to come down from his high throne. Some use the phrase M-deities. M-deities. The model of the M-deity is gone. He is your partner in healthcare, and he is going to make decisions with you as you, the educated patient, participate in that decision-making process. Now, that's scary for some people. They still want their doctors to be the experts, and I understand that. But you'll probably notice as you go to doctors, if you develop a disease, the doctor will lay out a number of interventions, a number of treatments, and he says, you decide which of those treatments you want to pursue. I'll help you, but you decide. Go on the internet and start researching how prostate cancer or breast cancer is treated in the year 2021. And you and I will decide together how a path forward. So this is a tremendous revolution, and God, it's incredibly powerful how this global internet is impacting all of us in medicine. And I'll just close with that. Let me also close with a personal thing that I've told my patients over the years, and sort of reflects my unorthodox approach toward medicine. Somebody asked me, Rick or Dr. Lippin, what is your healthcare plan? You know what I used to say to them? My healthcare plan is jobs for everyone. I agree with the economy. Nothing could be more important than having a meaningful job that you go to on a daily basis, that provides an income to you, that gives you decent benefits. That's my healthcare plan. My healthcare plan overlaps with what Paul Krugman says, and The Economist says about society. It has nothing to do with organized medicine. I want every one of you people out there online to have a good job. And when you wake up in the morning, you're doing meaningful work. And that has a huge impact on your health. Meaningful work has a huge impact on your biological well-being and your longevity. It's a wonderful path toward health. The other thing that I said, and when George Lundberg from JAMA interviewed me, I said, doctors ask you about the pain scale, what's your pain level, 1 to 10? I said, what? Doctors need to ask two fundamental questions to every patient on every visit, at least the primary care doctors. And you should put it on a Likert scale, 1 to 10, 1 being minimal, 10 being catastrophic. How are things at home? 1 to 10, 1 horrible. My wife and I fight every day. We're headed toward a divorce. 10 couldn't be better. My home is my sanctuary. My relationship with my wife and children is wonderful. How are things at home? Basic question. Number 2, how are things at work? Work, I love it. I can't wait to get there in the morning. I stay over because it sustains me. 10, I have a toxic work environment. I have a toxic boss. I'm miserable every day I put my foot in the workplace. These are called the relationships, the importance of the relationships in health. If you have good relationships, Shrikant and others, if you have good relationships at home with your spouse and your family, if you have good relationships at work with your coworkers, with your boss, with your underlings, nothing is more important to your health, in my opinion, than those two factors. Now you could argue, well, what about bacteria? What about viruses? What about the environment? What about genetics? Of course they're important, but I have a bias toward this concept of a path to personal health relating to good relationships at home and good relationships at work. And I'll just end by asking you that when you go to your personal physicians, please try to get him or her to have them question you about these things. Because if they don't, you're not getting your money's worth, and go on to another doctor. So I'll close with that. I know we've covered so much, but you've been a very patient audience. I haven't really kept track of all the time that I've taken, but you tell me, Shrikant, whether we should go to breakout and talk about some of these things. I mean, there's no limit to where we can go with some of these things. And thank you for listening to my views. And I'm not alone, by the way. Rick Lippin doesn't have all the answers. I have many colleagues who agree with me and who are sailing in similar waters. So, if I pass away next week, Shrikant, I'll give you names of 10 other doctors who could pick up my mantle. Okay.
Wonderful. Thank you, Rick. This was great. So what we're going to do, Rick, is we're going to go to the breakout room so we can discuss these ideas. I have again posted the entire summary that you have for everybody, so everybody has it. And then we're going to discuss this. You will also be part of one of the breakout rooms. After we discuss it for about 20 minutes, we're going to come back, and then people will be able to, people are going to give you their takeaways, as well as ask. Always, we have 4 rules. Go ahead and type exclamation mark in chat or raise your hand in Zoom in order to ask questions. Rule number 2, keep on topic. Rule number 3, be brief. Rule number 4, speak your mind. Feel free to disagree with anybody on anything and do so courteously. All right, so it's going to be Michael, Mike, Jean, and Linda first. Michael, go ahead.
Hi, Dr. Lippin. Thank you for the presentation today. So in our discussion in the group, and just throughout your presentation, it became apparent that the insurance has a large piece in this puzzle, so to speak, on how to basically move things in the right direction. And I'm wondering if you happen to have knowledge of healthcare cooperatives, health insurance cooperatives, so that people could spend more time. Are there any companies that are worth looking into, or that have a model that seems to be working from your perspective, that people can access holistic care and spend more time with their physicians in trying to, get to the root cause of things?
Rick, you need to unmute yourself.
Thank you for the question. I'm not that familiar with cooperatives. What I am familiar with is the work of Wendell Potter, who is a whistleblower who had been an executive with Cigna. And if he's on the side of just getting rid of the power of the insurance companies in medicine completely. The single payer movement, Medicare for all movement, is in favor of just pulling out and just bypassing the entire health insurance industry. And Wendell Potter happens to be a Philadelphian, and I wish I knew more about cooperatives. Clearly, insurance, the role of insurance in American medicine is huge, and quite very important, but very frustrating to doctors also, who have to spend a great deal of their time fighting with insurance companies to do what they think is best for their patient. So I'm sorry, your name, sir, who asked the question?
It was Michael, but yeah.
Michael, I'm sorry, I don't know much about the cooperatives, but it's my hope, actually, that major insurance companies, at least as they're behaving now, are reduced in their power in U.S. medicine.
Thank you. Thank you, Rick. Next up is going to be Mike, Jean, Linda, Kevin, and Elle. Mike, go ahead.
I resonate with everything you said, including the page that Shrikant faxed for us. The things that are under our control, direct control, are lifestyle things, and some of those things are controversial. A couple words: diet, big. There's the forks over knives thing. I don't know, Dr. Esselton, of moving toward a vegetarian diet and not necessarily the high-priced organic diet. What do you think about that? Another factor is exercise. What do you think about 10,000 steps a day? Would you do you subscribe to that? The previous two. The third thing is what happened. They say people don't sleep well, even if they sleep 5, 6, 7, 8, 12 hours a day, they still don't sleep well. What do you think? Do you have any personal subscription for non-drug induced sleep? And okay,
Mike,
thank you.
Three is enough. Let's
enough.
But
The general comment about lifestyle is,
Okay.
and I want to add one more thing. What do you think about artificial intelligence giving the personal answer to better record keeping and having the computer help the doctor know everything about the family?
Well, there's a lot. Thanks for your question. There's a lot there to talk about. As a doctor, if I had to prescribe a diet, it would be fundamentally a vegetarian diet. I think the amount of meat that we consume and sugar and salt is disgraceful. But so that's my answer to the exercise. Obvious, 1,000 steps a day. You don't have to be a vigorous exerciser. Walking or indoor bicycling, excellent exercises. The sleep thing, interesting that you bring that up, because that's not often brought up in sessions like that. That is a very important topic. The Sleep Association say the U.S. in particular is a sleep-deprived workaholic nation. Also, as we age physiologically, we don't sleep as well as we did when we were younger. It is a huge topic. In my opinion, becoming addicted to prescribed sleeping medications is not the answer, but the answer for good, healthy sleep is tough to achieve. It's a real challenge. I think it's going to be one of the major topics going forward in American medicine is how can we get an aging population to have good restorative 7 to 8 hours or even 9 hours of uninterrupted sleep per day. It's a real tough challenge, but I think it's an extremely important one, because what could be more important and restorative than getting a good night's sleep? So thank you for raising the sleep issue. What did I miss?
No, that's fine. We can drop AI. It's much more complicated. Next up is going to be Jean, Linda, Kevin, Elle, Laura, and Jyoti. Jean.
Yeah, thanks, Dr. Lindsay. We're very lucky to be in the same discussion room with him. Everybody have so many questions. I think this is such an important topic for everyone. So we really need more meeting like this. So my question is, like, I watch on YouTube, so many doctors change from Western doctor to functional doctor because through their own personal experience, they find out, like Dr. Gampi, they found out instead of treat heart disease, after it's everything clogged, maybe it's more effective and help them to prevent it even happen with lifestyle, nutrition. And you also mentioned, like the government really need to do something, because why there's so many people have chronic disease, from kids to older people. I know people get allergy after 50 years old, suddenly allergic to like wheat or rice or something they
Yes.
never be allergic to. Yeah, I think there's something wrong with our food. And the more I study it, I found out all the engineering of food, they make it so toxic and all the addictive. So that really need to be done. But also I think for the doctor part, maybe there need two, like doctor and physical therapy. They also need a nutritionist, as the preventive, health and maybe personal coach with exercise, nutrition. Then you don't really have to move to the last step to treat people after they already get very sick. So that's maybe I think functional doctor or preventive doctor maybe will be more popular in the future as people get more aware. But they need education. It's hard to study everything by yourself.
Yes, and I have said that if I had to start a practice of medicine, and I was in occupational medicine, which is worker health. If I had to start an individual practice of medicine, I would have 3 other offices right next to me. One would be an exercise physiologist, one would be a nutritionist, and the third would be a psychologist, a therapist. That's my team. Me, the doctor, exercise physiologist, nutritionist, therapist, all in the same office. And when you're finished with me, I want you to go see my nutritionist. I want you to go see my exercise physiologist. I want you to go see my psychotherapist. That's holistic medicine. Now, the answer to why, you said that many doctors are leaving traditional medicine and doing functional medicine. I still think the number, correct me if I'm wrong, I'll look it up. I still think the number is pretty small. I would like to see more doctors migrate to holistic medicine, but the economic incentives are not there, and it's not a fair playing field economically. So if we can see more migration of other doctors toward allopathic doctors toward holistic medicine, I'm happy to learn of that, and I'll try to understand the data better for the next time we meet as to how much of a migration is taking place. I will say this, as I've said for 20 years, the patients are way ahead of the profession. The patients, with their own dollars and with their own feet, are seeking out these alternative therapies, and that's been known for decades. So the profession has to come along now that the patients have led the way.
Next up is going to be Linda, Kevin, and Elle. Linda.
I don't think we've discussed something very important, which is part of the motivation of the 15-minute or less visit and impacts patient-doctor relationships a great deal, and that is malpractice insurance. The American public is extremely litigious. Some doctors have left practices, or their relationships with patients are more adversarial because they're afraid of being sued. Minor mistakes. Look at the ads on TV for lawyers. Don't you like the outcome of your delivery of your baby? Did you slip and fall? Did you not like what your doctor did? Your surgery isn't quite what you wanted. This destroys relationships. I'm not sure what the answer is, but look at all the obstetricians.
Oh yeah.
Who no longer deliver babies. They were burned so poorly with malpractice. Now how can we deal with that?
State legislative change. How can we abide, as you say, a system where doctors are constantly practicing defensive medicine, worried about being sued, to the point where in some states, you literally have to go to another state to have your baby delivered. That is bizarre. And there are political movements in various state legislators to tamp down the frivolous and excessive lawsuits. I'm not a scholar on that, but I totally appreciate and recognize the problem. Thank you for bringing it up. It's part of It's part of the problem in American medicine. What about other nations? Do they have this problem? I don't know. I don't know. It's sick. It's wrong and it's sick. And I know doctors who've been sued and they have been through hell and they have almost quit medicine. Some have actually committed suicide as a result of being sued.
Thank you. Next up is going to be Kevin, L, and Laura. Kevin.
Okay, thank you, Dr. Rick. I got a quick answer your question. Is how about other else? I would say globalization about westernization last 100 years or 50 years. So here's another way. My question is, what Western medicine can learn from a traditional care? The traditional way is mostly holistic medical care. For example, I know share about Chinese medicine. They use 4 diagnoses. They observe the situation, then listen the patient, then ask, then they do the blood pulse, use hand. So also indigenous people, they're doing good on their own. So do we have any research about that? Thank you.
Oh, absolutely. I mean, alternative medicine has been studied extensively all over the world. And for whatever reason, the pioneers in US alternative medicine have spent a great deal of time studying traditional Chinese medicine, as you know, and acupuncture being a good example, Chinese herbs being another example. But there's a great deal of research on various cross-cultural medical practices. Why do the French use so much homeopathy? That's a good question to ask. I will tell you this though, when I went through my Megatrends, I said that the battle between alternative and traditional medicine is over. The war is over. What we need is our efficacious and safe medicine, no matter what the intervention is. But the problem is that alternative medicine doesn't have a fair playing field economically. They don't get funded to do their research. So Chinese medicine doesn't get the funding that it should get in the US to be studied. And there's not compensation for engaging in certain Chinese medical practices, for example. So all of this is very important, but there needs to be a fair playing field economically to do research and to apply these practices in real world medicine, which brings in, does the insurance company pay for your doctor's interest in traditional Chinese medicine? I hope that the insurance companies begin to open up their deep pockets to allow for some of these practices. So thank you for the question.
Thank you. Next up is L, Laura, Jyoti, and Jade. L.
Thank you. Thank you, Shurkan. Hello, Richard. Richard, I live in New York State, and I would like your opinion of Governor Cuomo.
Well, let's not go into politics, okay?
Okay. All right. It's just a referent. All right. Yes, our senior and elderly who are being neglected in nursing homes, they cannot themselves incorporate some of this beneficial self-care that we're talking about. What can their families do for them? And if they're not being provided for example, in being able to embrace the naturopathic and this kind of treatment for themselves, and sometimes they're even precluded from being able to have this in a nursing facility setting or assisted living. What are the answers or best responses? And I'll open it to you, Dr. Rick. Thank you.
Rick, yeah, thank you. Very important question, given the demographics of our US population and the aging population. One answer that I'll give you is, and I feel very strongly about this, and I've written to some of the leaders in geriatric medicine who run nursing homes all over the country. Polypharmacy is a term that relates to the likelihood that one of your elderly parents will die from excessive medication use in a nursing home is as great as they'll die from natural causes. So to re-look at the excesses of medication use in nursing homes is a very good start. In Canada, there's a concept called de-prescribing, which means stand back from all the medications that your parent or grandparent is on in the nursing home and say, wait a minute, is it really valuable for my and healthy for my parent or grandparent to be on this many medications? Because I will tell you that scientifically, the possibility that they will die from a medication error or a medication overdose or a medication interaction is as great as they would die from their underlying disease in the nursing home. As far as moving alternative medicine into nursing home practices, I think we're a long way from that. I would like to see that happen, but I don't know of, I will look into this issue, but I don't know of that many nursing homes that embrace. There's a lot of, there's a lot of interest in hospice and a huge issue in nursing homes is falls. Why do patients fall so much? That's something that's being studied very, very carefully. But one thing that comes to mind, which interests me, which is not going to take the place of mainstream medicine, but I like the incorporation of the arts, music, paintings, dance. I like the incorporation of the arts in geriatric facilities because I think it you can't say that playing a song that a patient knew in their childhood is going to cure their cancer, but it certainly gives them some temporary relief from the struggles that they're going through. So that's sort of a broad answer, but I have a major concern with the amount of medication that nursing home patients are provided and failure to recognize that that's a dangerous path. I hope I helped.
Next up is going to be Laura, Jyoti, and Jade. Laura.
Hi. I've spent a lot of time in the medical world over the last year, so I have a few things I want to talk about. First, I know these days insurance, if you have to get it and you want to have it where you don't have to pay copay and all of that, and you sign up with these plans, you have to have a PCP, and that PCP plays a big role in guiding your healthcare, because they have to, if you need to see a specialist, they have to make the referral and so forth. And they also now have, in most of the teaching hospitals anyway, they have these My Health kind of things online. So they put the information, all the information goes into that system, all the test results, and everybody can see them. So any doctor can see the results and be involved in your healthcare in that way now, which they couldn't before. So one of the things is, as I recommend for anybody who has to see a doctor, I would go see if there's a university that has like a teaching hospital. I would recommend starting to see a doctor in that setting, because then you have the opportunity to have access to more doctors. And I know I've been able to create my own team of doctors in that setting. And what I do is I make sure when I see a doctor that doctor speaks to me at the same level he would speak to anyone else, and that he will speak to me and tell me everything I need to know. The other thing is that I find that my doctors are asking me, so what do you think? What do you think the problem could be? You know, because I do provide my diagnosis in effect. That was an interesting thing that does happen. I sometimes feel like I could have a doctorate degree at this point. But anyway, that's just something. And the other thing is, that I was
Laura, do you
gonna,
have a question for
no,
Dr. Lippin?
I was gonna ask the question really is that how do you think that, see, I think that how do you get sort of the average person to get like, I can be my own advocate, but I'm not sure everybody can be their own advocate. And I think that that is not fair. You know, everybody should be able to have some advocacy. So how can you teach a patient to become an advocate for their own health? Because I think it's really important that they can take that role, you know, on as well, so that they know what's happening and that they can become good decision makers.
Well, first of all, I like the painting behind you. Thank you very much for bringing some art into the room. Okay. Well, advocacy. I mean, look, I mean, I think part of my presentation had to do with the changing nature of the doctor-patient relationship. And every patient needs to be their own advocate, or if they're not able to mentally or physically, they need to bring an advocate with them to their doctor visit or to their hospitalization, because I've told my patients for 20 years, you live with your body 24/7. No doctor knows your body better than you do. Now, a doctor has technical training and technical skills, but you know your body. And, you know, I use the Sir William Osler quote, which is, if you listen to the patient long enough, the patient will invariably give you their diagnosis. So that's part of the doctor's need to listen. But I am in favor, you know, you use the word advocacy. I'm in favor of patients being their own advocate, or if they're not able to do it physically or mentally, they need to bring an advocate with them. And intelligent, modern doctors expect that relationship now. If they don't, find another doctor. Okay.
Thank you. Next up is going to be Jyoti and Jade. Jyoti.
Hi again, Dr. Lippin. Like I said in the breakout room, everything you said and everything you talked about was absolutely 100% right.
Wow.
Yes. I have to warn you, it's a utopian concept. It's not
Yes.
happening. It's not happening. I like to read about it and I like to hear about it, but a lot of things are not happening in day-to-day life with the doctors, with the patients and what have you. Somebody had raised a question about the lifestyle changes, and I'm very high on the list for that one. I hate to say this, every time somebody died in my family, my motivation to take care of myself went up, and it just keeps going up. So having said that, Michael, I think he had raised a question of, and you can tell me that too, about why the lifestyle changes, what are lifestyle changes and what have you. They are very simple changes. Eat your food as a medicine, exercise the best you can, stay with the nature, meditation. However, I will say one thing, and Dr. Lippin, you can tell me that, you can contradict me on that one. These lifestyle changes only reduce on the degree of ailment, but you will have an ailment in your life because the cellular changes start taking place when you get older. You have no control over that. No exercise, no nothing can help you with that. However, the severity will not be as much. It will still leave you functional. It will still reduce the hospitalizations. It will still give you a vigor in life. So am I right or am I wrong in that one?
Personally, I think you're right. Aging, unfortunately, is a series of losses. And while there are many scientists working on the aging process, I personally don't think that we're all going to die at age 90 healthy. I think we have a series of degenerative changes, and I think the lifestyle changes that many of us spoke about today modify that, but they don't, as you said, they don't eliminate it. They don't eliminate the aging process, in my opinion. What's the old quote? Grow old along with me, the best is yet to be. Well, that's a nice quote. I even have it in my garden, but realistically, and from a medical standpoint, it's probably not true. But one could say there's an imperative to live as if it might be true. So one has to try to recognize that as we age and become infirm, it's still better than being 6 feet under. It's better than the alternative, unless you're really suffering in pain. I'm not in favor of that. But we all want to live as long as we can, as long as we're not suffering. But I agree with you. I think that the capacity for lifestyle to totally eliminate the aging process is naive. So thank you. Thank you for that comment.
Thank you. Next up is Jade. Jade, go ahead.
So I know a lot of people brought up insurance. It was just quite literally yesterday, I got a group message about someone that I know who's in a hospital, who just went back to the hospital. And I think it's interesting to hear what's being said now, because this person is in danger of losing their home health visits from visiting nurse services and aides in the event that they don't go along with the doctor's recommendations. So, and it's one of the recommendations is pretty invasive surgery. But if they don't go with their surgery, they no longer qualify. I personally was wondering if that's coercive. I don't know if I'm wondering, I think it's coercive, because it forces your hand. If you want to maintain the help that you currently have and will need in the future, with or without the surgery, you have to, like, and so part of me, I'm still waiting for a reply. I'm like, is something missing from there? But I'm just wondering if this is a normal practice, because it just really sounds off. And then the second thing I want to say is that there are lifestyle centers that try to do holistic stuff. I don't know if many people, like some people know about them and they have like all these ideas. So let's just suspend judgment for a moment. And I'm going to bring the Seventh-day Adventists into the conversation. They get a lot of press about being weird on a lot of stuff, but they also get a lot of press on the concept of their longevity and their health. And they have like, there's one, I think in California, Loma Linda, there's Wildwood, there's UG Pines, and they try to take a holistic health going around it. Their spiritual thing is through the religion of the Seventh-day Adventists. So on that level, it might not be for everyone, but the concept and the dietary things, there might be stuff to get from there for everyone. So it's worth looking into. Take what you like, leave what you don't.
Right, right.
That's my 2 cents.
Very good. I'm not aware of that situation that you described where a person is forced to have surgery in order to maintain insurance benefits. I agree with you. It sounds coercive to me. I mean, surgery is an aggressive thing that people have to endure. And if you could send me more details, I'll give you my email address. I'd like to learn more about that. It sounds, I agree with the word coercive. As far as the Seventh-day Adventists or the Mormons, I mean, dietary, I think they don't use alcohol, caffeine, they don't smoke. I mean, of course, these are good behaviors, but I like your idea of taking what these organizations or religions, taking away what they're doing good from to apply to your own health care without necessarily accepting their religious beliefs. So I think that's a good concept, that, you know, that just because you study Seventh-day Adventist health practices, it doesn't mean you have to become a Seventh-day Adventist and go to their church. So thank you for that.
Next one up is Francoise. Francoise, you're muted. Go ahead.
Okay, it should work now. Sorry. Yeah, you were speaking about caring and hospice care and the progress of the hospice care. My question is about euthanasia, you know, because in Europe, there's more and more countries which are giving assistance for people who choose to die. What's your position, and what do you think is coming into the state? Will that be a possibility in the future?
Definitely. I mean, I view the United States as being immature and behind as a culture in regard to dealing with the entire death and dying issue. And it's a political third rail. As soon as you talk about unplugging someone, unplugging grandma, or pushing grandma in the wheelchair, or pushing grandpa in the wheelchair off the cliff, you know, you're accused of being a murderer. But to me, one of the most important aspects of a culture is how it handles death and dying. And I think America is behind. Euthanasia, there's active euthanasia, where you actively put somebody out of their misery, which happens all the time, although sometimes it's subterranean, it's hidden in the hospital. And then there's passive euthanasia, which is, if the patient is dying, you don't take any extraordinary measures to keep the patient alive, like hooking them up to machines. So 28% of the Medicare budget in the United States, which is huge, is in the last 6 months of life. It is, in my opinion, cruel to profiteer off the dying. For people to hook my grandfather or my father up to machines when they're dying is morally incorrect, in my opinion. So I think euthanasia is occurring in this country. The political right, the conservative right, Shrikant said, don't bring in politics, but conservative people in general are very much against euthanasia, just like they're against abortion. But in my opinion, it's one of the areas that US culture needs to improve upon, and I would be in favor of a humanistic approach toward death and dying, including euthanasia, both passive euthanasia and even active euthanasia. So that's my answer.
Thank you, Rick. Rick, I did not miss the fact that you said that you would be giving us your recipe for health.
Okay, I said it already, but I'll repeat it.
Yes.
My own personal recipe for health. You know, given the genes that we were born with, our God-given genes, given the hand that we're dealt, my own personal recipe for health. My healthcare plan is meaningful work for every able US citizen with good benefits. That's my healthcare plan.
Mm-hmm.
I agree with Paul Krugman on the jobs issue, okay, or Robert Wright.
Got it.
So for a doctor to say, what's your healthcare plan? Jobs for everyone. My personal recipe for health, we already spoke about some of them, but to me, because I have an interest in psychiatry, I'm not a trained psychiatrist, nothing is more important, in my humble opinion, for your personal health than good relationships at home with your spouse, with your children, with your loved ones, with your partners. Nothing is more important than good relationships at home. And the second is good relationships at work. These are health factors. Most doctors don't view them as health factors. They don't talk about them. My research over the years with governmental agencies and my observations with patients is that those two issues of relationships at home and at work account for a huge impact on your personal health. And exercise, nutrition, stress management, they're extremely important. But if Rick Lippin has a bias, it's high quality relationships. And I may be different than other doctors in that regards, but that's what I believe in. So thank you.
Wonderful. I'm going to ask you one more question.
Sure.
And, I want to talk about one more area. You talked, the most intriguing thing you said amazing things, but most intriguing things that you have said is your focus on art and medicine. You talked about, your association of doctors and poetry, I think, something like that, and 2 other associations. So tell us a little bit about that. Yeah, please.
Well, that's a whole other topic. We spoke about it before the session today, but yeah, I founded 2 arts and medicine organizations in 1976, the American Physicians Poetry Association and in 1985, the International Arts and Medicine Association. Why? Because in medical school, I recognized in myself that the arts helped me cope with medical education and the rigors of being a medical student and a doctor. And there's a great deal of interest globally in the rich relationships between the healing arts and the creative arts. Now, will I sit here and tell you that if you, God forbid, Shrikant, develop a cancer tomorrow, I'm going to come with my guitar and sing a song to you and you'll be cured? Of course not. But I'm going to tell you that there's a huge network of people all over the world who understand and appreciate the very rich relationships between the healing arts, which is medicine, and their creative arts, which is the arts. And that's another session or more. I'm very much involved. And thank you for asking me about that other interest of mine. But
wonderful.
I appreciated the lady in our group who had this beautiful painting. Usually when people do these sessions, they put books behind them like you, Shrikant, and like I have behind me here, books, but to show you the audience how erudite they are. I appreciated that one participant here in our group who had a nice piece of art, which presumably she did on her own. It was very, very nice. And that's why I started my session with the music from Scott Joplin, The Pineapple Rag, because I very much believe in incorporating the arts into our lives.
Wonderful. All right, Rick, this was a great honor, and we look forward to having you back. And I would like to really explore the topic of art and medicine further, because I think it's a very deep issue, and it goes to the heart of what you were saying about they forget that there is a neck here.
Thank you for picking up on that. It's pretty simple. The neck exists, right?
Yes. Wonderful. All right, so thank you very much for